Hello everyone, thank you for watching our group's debates presentation. I am Josie Nguyen from Southern California. I am the introducer of the group. Our debate is going to follow informal format, which we think is the appropriate and effective way to demonstrate our points. Our group members are myself, I will be the one conducting the introduction and conclusion for the group, as well as the illustration for the presentation. Brooke will be the summarizer, researcher, and tutor for the medical model. Candy will be the summarizer, researcher, and tutor for the sensory integration therapy. Laura will be the summarizer, researcher, and tutor for applied behavior analysis. After the conclusion, we will have Q&A at the end of our debate today. Our topic will be alternative models to address quality of care for children with autism spectrum disorder. Three popular theoretical perspectives that we are going to debate on regarding intervention for individuals with autism are the medical model, sensory integration therapy, and applied behavior analysis, ABA. As indicated in the name itself, the medical model mainly focuses on medical procedures where the licensed physician prescribes medication in order to reduce the impact of autism. Sensory integration therapy assesses the sensory needs of the individual with autism and provide treatment based on their needs. Applied behavior analysis, ABA, is the process of the systematically applying intervention based upon the principles of learning theory to improve socially significant behavior. During our debate, we will examine many factors among the three models. These factors include the influence of political, economic, and societal factors with research and findings about the impact of parent choice, professional autonomy, and the advocacy organization, as well as ethical dilemmas. Let's hear what Brooke has to say about medical model.
All right, so to summarize the medical model, they came about in the 19th century, and it was centered around the belief that a disability is the product of biology. The product then deviates an individual from normal functioning of daily living in which that individual cannot participate in society. This model believes an individual's impairment influences them in a negative manner. Um, the medical model focuses on the individual and their disability as the problem rather than the individual and their needs. Physicians play the role of diagnosing a child regarding disabilities and thus labeling them as disabled. Many physicians, through a biological standpoint, believe the proper way to handle a disability or a long-term mental illness is through medication to fix the problem or the abnormal condition. A common goal is to achieve normality. There are also parents with children who have disability who are for and those who are against the medical model. No matter one's position toward the model, one thing is certain, that the medical model reached people from different professions and backgrounds to start discussing the matter of disability and how treatment affects the individual and their families in our societies.
Sorry. Okay, so the summary for the sensory integration therapy is that I will review what sensory integration theory is, who it was developed by, and who uses it. I'll share information obtained from current studies and from journals that are peer-reviewed articles to show the research for and against sensory integration. I'll share the impact of parent choice, professional autonomy, and the advocacy organizations, and discuss some ethical dilemmas of sensory integration. Sensory integration is the process through which we sense the world around us. We use our sensory organs, so sight, smell, hearing, touch, to receive that information, and then we organize it so we understand our surroundings. Sensory integration is also where we perceive, organize, and modulate and interpret sensory information. The breakdown in sensory processing can affect our behavior, communication, and activities of daily life. Sensory integration was first identified by an occupational therapist, and her name was Dr. Jean Ayres, and this happened in the 1970s. She was the first researcher from the different therapy fields to identify this, and she defined the impact of what sensory processing does with learning and emotions. She also designed standardized assessments and created a set of intervention principles to follow. The next slide is just a slide to show if you have signs of sensory processing difficulties. And I know with my daughter that has autism, it was her clothing that really bothered her a lot. She couldn't wear long sleeves, and often the little line on the sock at the top was very bothersome to her. And so there's just a lot of different signs to look for on your children. And then how does our body take in this information from the environment? And we all know the 5 senses that we all learned in preschool. So touch, smell, vision, hearing, and taste. But then there are 3 others that are less familiar to people, and that's our vestibular, our interoception, and our proprioceptive receptors. And those are, vestibular receptors are responsible for detecting change in position in space, our balance and movement. And then the proprioceptive receptors provide information about our body awareness. And interoception, it involves our internal organs. So if we're hungry or thirsty, or if we have to go to the restroom and things.
Okay, so applied behavior analysis is also known as ABA therapy. It is an evidence-based therapy based on behavior and learning that helps us understand exactly why behavior occurs and how the environment plays a role in the behavior and how an individual learns. So some goals of ABA include decreasing problem behaviors that may interfere with learning, and increasing helpful behaviors such as language, communication, social skills, attention, self-care skills, and academics. It also assists an individual to live independently. ABA programming is formed based on the needs of a client. It can be provided in a variety of locations, including in-home, in-center, community, and school settings. It uses one-to-one teaching as well as group instruction. Now, ABA is provided by professionals, highly trained professionals, including RBTs, which are registered behavior technicians, BCABAs, which are board certified assistant behavior analysts, and BCBAs, who are board certified behavior analysts. Just to restate that ABA is, again, an evidence-based intervention, and it's proven to have positive results through scientific tests of effectiveness, quality, and usefulness.
So what are the research findings regarding each model?
Okay, so the research findings for the medical model show how the model categorized individuals with disabilities as disabled and non-disabled by focusing on the physical and biological aspects of a specific condition. It literally separated those with abnormalities from the deemed norm within society. The physicians became the gatekeepers for diagnosing a disability and its consequences. Physicians use problem solving through medical history, physical exams, and diagnostic tests to determine the deficit or dysfunction in a patient or for identification and treatment of an illness. The treatment of illness regarding the disability is typically through medication. The medical model did bring with it the ability to qualify for medical treatment, financial help, psychological, and social support. This support, however, is only available to those who are deemed disabled through various screenings from the government, insurance programs, military pensions, and the courts. And this means that some individuals who have a disability but were regarded as able in terms of able to work were unqualified to receive any support. Many models used today have stemmed from the medical model's approach to disability, such as the social model and ABA. ABA and the medical model share a common belief and goal of eliminating the symptoms of disorders such as ASD. ASD is treated similarly to the medical model by physicians because, according to the physicians, it's a medical problem that interferes with normal functioning, and thus it needs to be normalized, typically through medication.
So the research for sensory integration, there was a study done by Pfeiffer, Koenig, Keenly, Shepard, and Henderson in 2011, and they found that preliminary results do support using sensory integration interventions in children with ASD. The results identified significant progress towards individualized goals and a decrease in autistic mannerisms after the client received SI interventions. The results also suggest implementing interventions that are generalized to home and community settings, using tools that allow for individualized sensitive measurement in future studies, and completing future studies with larger samples. And that there's a lot of future studies that need to be done. And then there's research also that is against sensory integration. And Dr. Shaw is a psychologist, and he states that sensory integration does not work, and there's no evidence that it does work. And it's never been effective for children that have learning disabilities, autism, or any developmental disabilities. He says that there are plenty of quality outcome studies, and there is no study that uses a quality research design. And however, for a procedure with no evidence or efficacy to be used on the public with claims to success, to charge money for these services and to train practitioners in this model borders on unethical behaviors. So to summarize the research for sensory integration, there are many studies that do exist that suggest that sensory integration does work, and there's also several studies that exist suggesting that it does not work. And so sensory integration is effective, and it's used by an occupational therapist using a sensory-based approach, and it's neither proven or unproven at this time.
Okay, so there is nearly 40 years or more of empirical evidence for ABA therapy. So to start off, there's a positive humanistic influence on ABA therapy. So the aim of a humanistic therapy is to improve one's self-image. And this can be difficult to record, but we can see it through the progress made through ABA therapy. Research from Bailey and Birch and Fryman have reported that individuals who receive ABA therapy actually gain an improved quality of life, productivity, and nearly extinguishing all potential life-threatening behavior. Lovis's research can also back this up. So he conducted an experiment to implement 40 hours of behavior therapy a week with his participants, and it resulted in improvements in IQ, social development, and his participants were mainstreamed. One thing that should be considered from this research is the intensity of weekly hours. I want to take a look at this table. It describes the beginning of ABA therapy intervention versus after receiving ABA after 10 months via the GARS scoring. So GARS is short for Gilliam Autism Rating Scale, and it helps identify autism in individuals, and it estimates its severity. So the higher the score, the more severe autism the individual has. And this table specifically reports that after having 10 months of ABA therapy, that the GARS scoring decreased by 25 points. Now, politically speaking, it does play an essential role in ABA therapy. The Applied Behavior Analysis Education website reports that in nearly all 50 states, excluding Idaho, there have been insurance laws that have been passed to ensure the governing of ABA treatment for those with ASD. Now, through these laws, services are fully acceptable to families due to ABA being deemed as a medically necessary form of therapy. Insurance laws differ between each state, but overall they each have an age restriction, coverage, and visitation limits. Now, social influence also plays an important role in ABA therapy. Wilson and Matthew reported that social validity of treatments can help determine the social importance and acceptability of interventions. And then they concluded that using the opinions of society can help researchers be a little more receptive to consumers or communities that are directly affected by ABA therapy. However, it should always be remembered that the behavior analyst should use the most effective treatment in the least intrusive way. Lastly, from an economic standpoint, caregivers of children who have ASD do face an economic burden due to the high costs that are associated with ABA therapy. So McPhillamy and Dillenberger, they reported that families have had to sell their homes, remortgage their homes, or even take out a bank loan to cover their therapy. Today, Marcus and Mendel have concluded that there should be a universal healthcare system and an improved workplace policy should be made so that it recognizes the full impact of autism.
So what is the impact of parent choice, professional autonomy, and the advocacy organizations for each model?
All right, the medical model, as previously stated, it labels individuals with disability as the problem along with their disability. This does not settle well for many parents who have children with disabilities. Disability is, for most of them, understood to be caused by prejudice, oppression, and the denial of agency and autonomy. Mothers want to protect their children from discrimination they fear in the future. In one study, parents who have a child with a disability were given the opportunity to share what they believe disability is defined as. Many parents' answers reflected the medical model in terms of how society views the disability of their child and how it sets limitations because of the disability. Limiting participation, requiring help, support, and assistance, and deviance from the norm are a few of the categories in which these parents' answers reflected. These answers focused on the direct consequences of the child's impairment. Other parents regarded the medical model and the professionals who diagnose and treat their child with a diagnosis as having written off their child because of their disability and not giving them the proper intervention and opportunities to overcome their disability. Physicians and other clinicians are the gatekeepers of disability status and the primary experts on disability and its consequences. The role of such experts is to determine the proper mix of cure, rehabilitation, and support appropriate for a person's impairment. One of the health professions, psychiatrists rather than psychologists, have adopted the medical model and have mainly used drugs to treat mental illnesses such as schizophrenia, depression, and OCD. And this picture right here is just showing how the impairment is the problem within the individual with a disability.
And then the impact of parent choice with sensory integration is that it's preferred by parents. It's an easy thing that they can do with their children at home, and it's often given to them through an occupational therapist. They also, in sensory integration therapy, they use play activities and ways to design and change how the brain reacts to touch, sound, sight, and movement. And so it is a good, parents really like that choice. As a professional, a pediatrician should talk with the families and let them know that the data on the use of sensory-based theories for childhood development and behavior problems are, that it's not really proven or unproven at this time. And there are a lot of advocacy organizations, SIGN, which is the Sensory Integration Global Network, and then the STAR Institute for Sensory Processing Disorder, and then also Autism Speaks. They do a lot of funding for research for sensory integration.
Okay, so in regards to parent impact, McPhillamy and Dillenberger's research has shown that the impact of parents choosing ABA therapy has actually provided them with positive dramatic changes, especially in their ability to manage family outings. They have lower stress levels, a better quality of life, and a positive outlook on their child's future. Families typically stated that they were more able of doing things outside of the home thanks to their exposure and learning how to deal with difficult problem behaviors via ABA therapy. I want to refer to this second table here. So this table shows the parental effectiveness of ABA therapy on specific target behaviors such as social skills, communication, gross and fine motor skills, concentration, and overall quality of life. So the majority of the target behaviors, they fall under level 5 and 4, which are the two highest scores showing very effective progress. The impact of professional autonomy will be discussed later on in the debate when I review ethical concerns within ABA therapy. Advocacy organizations actually have a big impact on ABA therapy. Specifically, Autism Speaks. So they seek to promote independence throughout the lifespan of an individual with ASD, and they provide support and advocacy to the individual and their families. They aim to increase understanding and acceptance worldwide, and they have actually increased autism awareness by over 50%. They play a role as a catalyst for research, and they do this by pushing for increased federal funding that can be applied to autism research. And they also aid in increasing the timely manner of early childhood screening.
Thank you, Laura. Let's talk about ethical dilemmas for the three models.
The medical model and ethics, individuals are classified as having a disability by the physicians, and this labels them for the rest of their lives. It puts a wrench in their quality of life within society based on the medical model and many programs for work through different screenings and tests. If someone is disabled and they pass tests as someone who can work, they're no longer considered disabled, and they can no longer benefit from certain financial help, psychological and social support, which limits their ability to thrive within society and marginalizes them. The medical model's ways of treating illnesses and abnormality through medication doesn't give an individual the quality of life they are encouraged to have via other interventions and treatments. Other treatments try to integrate an individual with their disability into society so that they can function as a normal member of that society.
And some of the ethical concerns with sensory integration is that we don't really understand how it works and if this approach works on all children who have sensory issues. Also, the explanation of sensory integration seems logical, but it's not based in careful study about whether that logic is actually true. And then another concern is that the lack of research that clarifies how and how much they work to improve a child's functioning and studies are poorly constructed. So they're too small of a sample size, and so it actually shows that the treatment isn't working.
Okay, so Dr. Simmons-Reed explained that there are 5 main ethical concerns in ABA. First is the right to effective treatment. So basically this states that you do no harm and you benefit others. Second is the responsibility to recommend scientifically supported and most effective treatments. In this case, the behavior analyst should always advocate for respecting autonomy, and we should always promote client independence and self-sufficiency. Third is that the behavior analyst's assessments are sufficient to provide appropriate substantiation for their findings. So behavior analysts should never start an intervention without running assessments or ever seeing the child. You always need to make sure that decisions are based on data. Fourth is the multiple relationships and conflicts of interests. This may include interactions with the child or families that may go beyond the role of the therapist. And last is the functional assessment. So concerns associated with this includes like lack of resources, professional judgment getting in the way, and overemphasis on descriptive assessments versus experimental assessments.
So let's sum up where we stand in this debate. Autism is a lifelong disorder and is found worldwide in families of all racial, ethnic, and social backgrounds. Based on the Center for Disease Control Prevention 2014, the prevalence of autism is now 1 in 68 children in the United States. They report that boys are 4 times more than girls in having autism across racial groups, ethnicity, and social economics. Nowadays, the field of autism is still unknown. The work of finding effective treatments for autism is still in progress. The 3 popular interventions we are debating on today are medical model, sensory integration therapy, and applied behavior analysis, ABA. We have analyzed these 3 models based on different factors, and we came to the conclusion that applied behavior analysis is the best model among the 3. Following our conclusion is the Q&A section where we will answer related topic questions. Our first question, how do you respond to a parent who decide to quit ABA therapy in lieu of alternative treatment?
So I'll answer this one. So I would, first off, I would inquire as to what the families feel uncomfortable with within the therapy and where they feel like their child is not making progress. I would also gather all data and graphs to share as visual supports to show the progress that their child has made, without the expectation of all this information changing their minds. And from a professional standpoint, I would have to respect the decision of the parents and be there as support with any information that they may request regarding declining further services. Now I have a question. So Brooke, how do you approach a parent when you realize that an alternative therapy may be impeding progress in therapy?
So I guess just like it's never easy to approach a parent with anything that is negative that involves their child. But I believe it's the ethical duty of us in regards to the physical and mental well-being of the child. Keeping an open line of communication between parents and other professionals involved in the child's treatment and progress is a key to successful intervention. And if meds have increased in aggressive behavior, then using your best judgment and notifying the parents of the effects is the best way to have successful intervention, keeping the best interest of the child. And then last question is for Candy. Do you have any personal experience related to this topic that you would like to share?
I do. So I do have some information or knowledge about the sensory integration. I have a 19-year-old daughter who is autistic. And when she was younger, we did music therapy and also horse therapy. So starting about age 4, she really didn't, the music therapy, she had to wear these certain headphones or headphones, and so she could listen to the different depths of the music. And then the horse therapy she loved, just being on the animal and being able to, she just really loved it. She was always happy when we went. And as a parent, I always felt like that those were good choices for us. One, they never, I didn't feel like they would ever hurt her. And so I only felt like they would benefit her. And so they were good choices for us. I have a large family. And so ABA, trying to get in 20 plus hours a week, was just extremely hard, trying to do that. So the sensory integration was something that we could do on our end. And then ABA, we kind of just had at school. So that's my experience.
Thank you for sharing with us. So I think this will conclude our presentation. Thank you for watching.